Greetings, everybody. Welcome to our regular CME presentations. Today, we are graced by Dr. Keisher Hoyte from the island of Barbados in the Caribbean. She's currently pursuing a fellowship in perioperative medicine at the University College London Hospital. She did her postgraduate training in anesthesia and critical care at the University of West Indies, Mona campus in Jamaica. So, Dr. Keisher Hoyte, welcome. As usual, post any questions or clarifications in the chat box. And if you'd wish to ask a question, you could just raise your hand, then we can unmute and go ahead and ask your question. So, Dr. Keisher, go ahead. Floor is yours.
Thank you. Good evening, everyone. I want to thank you for extending the welcome for me to do this presentation this afternoon, and I hope that it would be quite informative and you'll be able to take away something from it. So this afternoon, we're going to look at prehabilitation and cardiopulmonary exercise testing. I'm not sure why we are not advancing. Okay, so just to say that I have no disclaimers to announce for any of the products that we're going to be talking about this afternoon. And our objectives are to define prehabilitations and its principles, to analyze the clinical evidence and the relevance of prehabilitation. We're going to look at cardiopulmonary exercise testing and it being the gold standard for risk stratification. And we're also going to look at some other risk stratification models to see if they're comparable to the... Hello? Hello?
Sorry for that. You can proceed, Doc.
Oh, okay. And the cost effectiveness of cardiopulmonary exercise testing. So firstly, we're going to look at prehabilitation. So this was really a concept that was coined from the military. It was noted that during the time when soldiers were preparing for war, they had a process of going through physical training and psychological training in order to put them at the best optimum condition for war. And so during the course of time, this concept has been adapted into our medical arena, in which we look at prehabilitation, focusing on the period between diagnosis and in preparation for surgery. And the main purpose of prehabilitation is to put our patients in the best optimization and to improve their pre-morbid state to help them to have better outcomes in their post-operative period. So prehabilitation involves a number of principles. It looks at improving functional reserve through the use of physical exercise. It has a psychological component in which our patients are prepared psychologically for the experience or the perioperative experience. It to look at enhancing or improving our patient's nutritional status, because as we know, surgery being a catabolic state, having the patient in the best pre-optimization nutritional status would help also improve our post-operative outcomes. And in addition to these pillars for our prehabilitation pathway, we noted the impact of other significant confounders on patient outcome. And so patients are also entered into smoking cessation pathways, anemia pathways, and alcohol cessation pathways. Looking at our graph on my right, sorry. It is a pyramid with the prehabilitation intervention to optimize functional capacity on the y-axis. At the bottom of the pyramid We're looking at all of the risks after risk stratifying our patients. We're looking at all of the modifiable risks that we can improve with the hope of improving our cardiorespiratory function and our muscle function with the objective of improving our functional capacity. So our rationale for having patients involved in the prehabilitation pathway is to improve surgical outcomes. We want to decrease morbidity and mortality incidences. We also want to improve postoperative complications that usually would occur within the 30-day period post a procedure. And we have recognized that even in the absence of any complications, there's a reduction of about the 40% in postoperative physical function. And so with prehabilitation, we're aiming to put our patients in a better pre-op condition in order to go through the perioperative pathway. So we've spoken about operative pathway. So really, what is it? It looks at our linear progression of our patient from the time of diagnosis to the time in their post-operative period. And it basically starts with our multidisciplinary team, usually composed of our anesthetist, our surgeon, our physiotherapist, dietitian, and so forth, depending on the needs that need to be optimized for the patient. And so our multidisciplinary team are responsible for assessing our patient and risk stratifying our patient in order to have a care management that is in keeping with the patient's concept of their quality of life. So onto the ERAS, is mainly focused on period which for surgical and technique that the main patient's physiological status so that we do not deviate significantly during the intraoperative period to put our patients in a better post-operative setting in order to minimize our post-operative complications. And then we have our rehabilitative phase in which the patient then undergoes the implementation of nutrition and exercise and so forth. So the aim of our prehabilitation pathway was that we saw the need to optimize our patients in the preoperative rather than just postoperative. So prehabilitation really is optimizing our patients from our preoperative setting, and it continues all the way into our postoperative setting for rehabilitation. So the concept of the prehabilitation model basically focuses on the fact that surgical intervention is a catabolic state because of the stress response to surgery. There's an increase in the O2 consumption. And so with prehabilitation, we're able to condition, improve our cardiovascular, respiratory, and muscular system with exercise over time. And it really tends to shift the focus from the post-operative or the more proactive of care to from a more reactive model of care to a more proactive model of care. And before, it really is optimization from in the preoperative period. If we look at the graph, this was taken one of the founding studies that was done on prehabilitation, where it looked at improving cancer care before treatments. And what it really is looking at is what the patient's general health is in terms of patients that have undergone prehabilitation versus patients that have not undergone prehabilitation. And if we look here, we see that persons that have entered the prehabilitation, they are actually on the higher end of the curve in terms of having a better recovery than persons that did not enter the prehabilitation pathway, and so undergoing treatment and so forth, they are on kind of like the lower end of the curve in terms of general health and the recovery phase. So with prehabilitation, it really looks at improving lung function of the patient or the patient's capacity to exercise. And this is correlated to a decreased risk of postoperative complications. And also persons, when they were risk stratified as probably being at the cutoff mark for having an inoperable surgery, or surgery not being offered as a modality of care management, with prehabilitation and improvement in functional capacity, these patients may actually be able to move a little higher up on the curve where they're now being able to be offered surgery as a modality of care. So with pulmonary rehabilitation, a number of studies were done in order to investigate the type of exercise regime and the time frame that would be beneficial to the patient to have them optimizing the preoperative period. And so just to mention two of the modalities was the high intensity interval training and endurance training. And what it was found is that in the study with the endurance training, patients had a faster improvement in their functional capacity in a shorter period of time. And so this was more so the exercise regime of choice. Usually they found in the studies that pulmonary rehabilitation took from 4 to 8 weeks to get patients at their optimal functional capacity level. However, with endurance training, with as minimum of 2 weeks, they were starting to see improvement. However, the improvements were better with prolonged periods up to 8 weeks. So the outcomes of this study had looked at how there were decreased complications in the post-operative period. There was improvement in the maximum oxygen consumption, and cost effectiveness. Cost effectiveness being measured in parameters such as your length of hospital stay or readmission post-surgical intervention. And it was cost effective because with persons undergoing the prehabilitation program, there was a decrease in the length of stay and a decrease in the incidence of readmission to hospital, which basically helped with a reduction in hospital costs. In the prehabilitative model, I had mentioned earlier that it involves a number of pillars or principles involving the physical, exercise, psychological, and nutritional. And so over the years, what was noted is that persons entering the prehabilitative program would be more focusing on physical exercise in order to improve functional capacity. And in this study, preparing the patient for surgery to improve outcomes, they looked at the prehabilitative modality as a conjunction or as a bundle of including all of these to work in synergy. And so the study had found that with the multimodal prehabilitation program, it may improve surgical outcome, facilitating rapid recovery from surgery, and limiting costs and limiting post-operative functional dependence. So in this model, the underlying disease process and your fitness for surgery, and I put fitness for in quotation marks because that has different connotative views for different depending on different specialties, but our aim basically is to improve your functional capacity, and also engaged in patient education and compliance, because in order for the program to work, we had to be able to motivate patients in order to stay in the physical exam regime for the time period that would be allowed for the prehabilitative pathway. So with our multimodal prehabilitation, the pillars look at what are screen tools, how do we assess or risk stratify our patients, and then how do we go about implementing this prescribed size or prescribed prehabilitation regime. So the aim is to implement or to refer the patient the prehabilitation pathway as early as possible, so that they can have the benefit of the time interval to improve their optimization. It helps with the advancement of treatment, and the screening aligned to the holistic needs of the patient, and it should also include the psychological risk factors, fitness and nutrition. So looking at our nutritional rehabilitation component, the American Society for Enhanced Recovery and Perioperative Quality Initiative Risk Stratification, they have proposed the use of a perioperative nutritional screen as an initial screening tool. And this uses criteria such as assessing the patient's nutritional risk. It used parameters such as their BMI change, pre-op albumin levels, because as we know, albumin is associated with one of the nutritional status. And so these patients, when they were assessed, any person having a score over 1 was then referred to the dietitian, in which they would then implement the different supplements that would be needed to help improve status. With our improvement in our functional capacity, which basically is our physical exercise part of the prehabilitation, these patients also undergo screening tools, where you can have screening tools such as your self-reported physical activity screening, or you can use other more objective screening tools such as your dual activity status index, clinical frailty score, which more so would be done among our elderly patients, 6-minute walk test. All of these tests really were to risk stratify our patients in order to be able to prescribe the type of regime that would be needed in order to improve patients' functional capacity. This study is a recent study that was presented during the ACPLUM conference in 2003 of June this year, and it had looked at rehabilitation, especially with exercise, decreases tumor burden, and the proposed mechanism was vascular shearing and immunity, in which if we look the picture here, it depicts the picture of a tumor, and this is the tumor in the environment of a patient that has reduced exercise or sedentary. And so we can see the growth of the tumor here, and that because of the reduction in exercise or the sedentary lifestyle, there is decreased blood flow and cardiopulmonary output. And so therefore our cells, our inflammatory cells, the incidence of being migrated tumor are reduced, as opposed to in the post exercise period, where we increase in our blood flow, increase in cardiac output, increase in recruitment of our inflammatory cells, especially such as our macrophages and our or natural killer cells, there is a reduction in the size of the tumor because of the increased exposure of the tumor to our inflammatory or cells of immunity. And so this study was put forward as a reason or to supplement the prehabilitation and the benefits of prehabilitation. So psychological prehabilitation looks at the patient's emotional status prior to surgery. And as we can understand, or as we can imagine, persons that, for instance, having a borderline personality disorder where they tend to have a tendency towards depression or anxiety, these emotional states already puts the patient at a catabolic state, which then during the intraoperative period, which is also a catabolic state, could have a synergistic effect on the body. And so with using the screening tools, for example, like our generalized anxiety disorder assessment, we are able to assess these patients and then to implement the interventions to reduce the preoperative stress through different our targeted behavioral interventions, muscle relaxation technique, guided imagery, deep and our mindful meditation, and so forth. So what are our limitations to the prehabilitation pathway? One such limitation is cost effectiveness. So many clinical studies have been done at the benefits of prehabilitation. However, the data that have been presented have been mixed. In some studies show that there is improvement in our post-operative outcomes, while other studies show that there is no statistical significant improvement with the use of prehabilitation. And this is mainly because of the heterogeneity of the type of studies that were done and the outcome points or the outcome endpoints that were evaluated because the outcomes were not a standardized outcome. Therefore, we had varying types of data, results for the data being put forward. Other limitation would our entry point of referral. At what point or what is the optimal point for the patient to be referred or to have the maximum benefit for the program, for the prehabilitation program? Because as you can imagine, it is a time sensitive type situation where surgery we cannot delay in order to have prehabilitation, and we need a minimum time interval in order for the patient to be optimized and to benefit from prehabilitation. And so therefore, it is not prudent to delay the surgery or to delay the time of surgery in order to do the prehabilitation. So therefore, at what point would be our optimal point or earliest point to refer these patients to the prehabilitation team? And then it would be who would be responsible for the referral of these patients. So our stakeholders being the anesthetist, our prehabilitative team, our surgeons, it is a matter of which specialty is going to be our champion in order to promote the prehabilitation pathway and to refer these patients to the prehabilitation pathway. So I don't know if persons want to take a 6 minute before we enter into the other part of the presentation, which is cardiopulmonary exercise testing. And I think I talked through our 6-minute stretch. So cardiopulmonary exercise testing, what is it? It is a non-invasive, dynamic exercise simulation test performed in a controlled environment. The aim is to assess our cardiovascular, pulmonary, and musculoskeletal response to physiological stress, and it provides objective evaluation of functional capacity and peak oxygen consumption during exercise so that we can risk stratify our patients. Because as we know, cardiac output is basically coupled to ventilation, and with increased demand or increased stress, where we increase our cardiac output, we also increase our ventilation. And so patients that are able to respond to these changes or the physiological demands are patients that are better able to cope with the stress response to surgery. It also has a diagnostic and prognostic information that is obtained from our cardiopulmonary. So this is an example of a patient in a cardio doing a CPAP evaluation. The patient is on a ergonomic bike, and the monitor is placed on the patient prior to the start of the test. Non-invasive blood pressure monitoring, oxygen saturation, and our electrocardiogram monitoring. These vitals are taken at baseline, and this is done before the patient starts the test. There are different protocols for the type or the regime of the tests that are done. For example, you have the Bruce or the NO, and what they basically do is to define the time interval, the intensity of test, if it is a ramped intensity, and based on the patient's physiological status. So the test is indicated for patients where we want to stratify or we want to have re-stratify their level, their disease state level. So patients that have coronary artery disease or heart failure, and we want to risk stratify these surgery. There are absolute and relative contraindications to having the test done. Absolute contraindications will be persons that are having active cardiac ongoing events, such as your unstable angina, and your relative contraindications to persons that have your non-symptomatic heart failure. And criteria for early abortion during the test would be changes in which the patient reports chest pain, feeling syncopal or pre-syncopal events, and obvious ST changes on our ECG. So the function of the CPAP. Some of the functions earlier, it has a diagnostic and prognostic evaluation of cardiovascular and pulmonary disease state. It assesses the patient's functional capacity. It gives an objective about the patient's risk, and this can be used in order to have decision making to decide on modality of management for the diagnosis. And usually shared decision making is in keeping with patients' concept of what they consider is their quality of life. It can also be used to ask optimization, comorbidity optimization, and prehabilitation, to evaluate the efficacy of therapeutic interventions, measurable goals to improve fitness, to measure exercise, rehabilitative training intensity, of the severity of disease states, evaluation of undiagnosed exercise tolerance, especially in our patients that have undiagnosed dyspnea. And it's used for quality assurance, in which the information is used to help improve the program, or improve or what can be improved in the program, and basically for development of our knowledge and understanding of disease processes. I had mentioned there are a number of parameters that are measured during CPAP testing. The more common parameters that are evaluated are peak oxygen consumption, and this is the oxygen level that is independent of workload. So at which point is our oxygen capacity or oxygen delivery independent of what our exercise activity. Our peak oxygen or maximum peak oxygen consumption, and this basically is a measure of our functional aerobic capacity. This measures our oxygen level at the point where it is transitioning from aerobic to anaerobic respiration. There is the anaerobic threshold, which is the maximum oxygen consumption at which lactic acid begins to appear in the blood, or it can be measured on the graph as 60 to 70% of our maximum peak oxygen consumption. Other parameters that are measured is our ventilation expired gas, and this looks at the increase in our CO2 if the increase in our ventilatory rate is of increasing activity, and our respiratory exchange ratio, which is basically a crude index of our anaerobic threshold, and this looks at the point where CO2 begins to increase with respect to our O2 consumption. So the American Heart Association, American Cardiology, they had proposed that our functional capacity assessment can be made clinically when we do our interview, our consultation, and our risk assessment of our patients, where patients have a metabolic equivalent of more than 4, which are considered to be able to do moderate exercise, persons that can proceed to surgery without further investigation. So our risk prediction models, they focus on assessing cardiac risk. However, our CPAP predicts all-cause morbidity, and we have discussed the parameters on the previous slide that CPAP allows us to. And this table really just looks at the normal values or the cutoff values for which these parameters in normal range. So CPAP, even standard, it's a resource intense type modality. Implementation comes at a significant cost. And so there were various studies. The most monumental study in which it was looking at other risk prediction models that would be comparable to our CPAP in order for us to risk stratify our patients. And the Duke Activity Status Index and was one of the tests that was assessed in that study. Other functional capacity tools would be like our 6-minute walk test and our incremental walk test. So our Duke, our DASI score is a patient-filled activity questionnaire where it has about 12 activities listed for the patients to score, and these are based on the criteria that these questions are reflective of assessing functional capacity. The score is extrapolated to give a predicted peak oxygen consumption value, in which we use a formula and the area under the curve in order to derive at the peak oxygen consumption levels. And ideally, a peak oxygen consumption of more than 15 mils per kilo per minute are persons that are at high risk. There's also a modified DASI score, which has 4 or 5 questionnaire components, and it was found that 3 out of 4 gives a 59% probability of anaerobic threshold being more than 11 mils per minute, which again risk stratifies our patient at being at very high risk. So these basically are just the other criteria for risk stratifying our patients based on aerobic threshold, peak oxygen consumption. It was found in the study that our DASI score was the only tool as a risk assessment tool that predictor of 30-day mortality and non-fatal MI. When we look at our 6-minute walk test, which is a test in which when the patient is walked a distance of meters, which are marked by cones, and the time that the patient takes between the cone is timed, and the entire process is done for 6 minutes. So in the study where it looked at the classification of cardiorespiratory fitness using the 6-minute walk test, it was found that our 6-minute walk test was comparable to using our CPAP testing. So what they did was they look at cardiorespiratory fitness. They classified it using the 6-minute walk test and using our maximum peak oxygen consumption values from our CPAP testing. And they looked at them and they saw that they basically correlated and that they were also dependent on sex and age. And so there was a table that was then constructed based on the values that were derived from the curve, where we had the table based on sex and age as to what would classify or stratify our patients going from very low risk to very high risk. They found in the study that the 6-minute walk had good correlation for all of the different classifications, except for differentiating between good and very good in terms of risk stratification. But however, it was very comparable to CPAP results when it to assessing patients that were in very low status, which were low incidence, which were low classification, which then were the patients that were at high risk for post-operative complications. Our incremental walk test, however, when they did the study, even though it showed good correlation with our CPAP testing, it wasn't validated because it wasn't done in a large enough population and it wasn't done as a prospective study. So based on the clinical trial that was done to assess the DASI score, one of the other factors that it found was that the DASI score was a good prognosticator for high score to risk stratify high-risk patients. And so we're going to look at the cost effectiveness of CPAP testing. In the NICE guidelines, cost effectiveness is defined as the expected cost of the option to expected health benefits, and it doesn't take into account total and cost for implementing the modality. So what do we need for our considerations for implementing modalities CPAP testing? We need to first look at what is our need for change. This can be through our audits for what our surgery outcomes are like, if they're what the incident poor outcomes are in our hospitals, and if with implementing CPAP testing, if it is to significantly or statistically significantly improve our post-operative outcomes from the risk stratification tools we currently use. We also need to look at our population. So there was an audit that was done where it showed that 319 million operations occurred yearly around the globe, and about 17% had post-operative complications, and 32% of these post-operative complications were related to persons that were high risk, and 20% of these high-risk patients were elderly. So when I looked at Kenya's population, I saw that it's about 53.8 million persons. And contrary to the studies that have been put out by WHO, where it basically looks at shift in the age group population, where we're having a decline in birth rate and increase in longevity, and an older population with an older percentage, with an older population percentage presenting for surgery. When I looked at Kenya's distribution, I found that 50% of the population under the age of 25, and the median age group was about 20 years old. So then looking at implementation for CPAP testing versus the cost effect benefit, I would leave that for persons to decide. Accessibility is also one of the things that if you're going to implement CPAP testing, considering that it's a resource intensive type modality, to look at things like cost of equipment acquisition, maintenance of equipment, and training of specialized staff, and the availability of which hospitals this particular modality would be available. Again, looking at the distribution of Kenya, where 30% of the population is urban and the majority rural areas, then it would be somewhat of transportation and accessibility as a consideration for if implementation for such a program is actually beneficial or cost effective. And then looking at what are alternatives. So I had looked at the alternative tools for risk assessment, like the 6-minute walk test, which had proven to be have comparable validity to CPAP testing, even though CPAP testing is the gold standard. Then it is the alternative modality because it has such credibility. Would it be cost effective in order to implement CPAP testing, especially in the face of clinical studies where we have varying statistics or varying data to support if CPAP testing is actually cost effective, or if it is actually needed in comparison to be the other risk stratification tools that we use in order to risk stratify our patients. So those are the considerations, I guess, that we can discuss in the question and answer. And thank you very much for your listening ear. And I believe open to questions.
Thank you very much, Dr. Keisher, for that wonderful presentation. Mine, I have a question. In a way to try and cut down cost, could home-based exercise be an option for some of these, as opposed to having this done within the hospital setup? Maybe a comment on home-based prehabilitation.
Actually, our studies that had looked at home-based exercise regime, and the data is quite varied, because it looks at things like compliance, actual implementation of doing the exercise regimes correctly. So they had looked at different remote area accessibility, video calling, so forth, in order for patients to participate in these exercise classes from the comfort of their home. But like I said, the results from the data are quite different in terms of patient compliance, the ability to perform the regime, the exercise regime correctly, and those kind of confounders that would basically affect the effectiveness of trying to use this as part of the prehabilitative pathway.
Thank you. Any other questions from the audience? Dr. Gashi, I see you're unmuted. Do you have something to say?
No, not really. Maybe somebody else can.
Okay, any comments, clarification from the audience? Okay, so maybe the assumption is that the topic was very well explained and well understood. So there being no other question, I'd just like to make a reminder to our KSA members of our upcoming conference that is coming up in the next 2.5 weeks. You can proceed and register in the link that's been provided in the WhatsApp group. We also have slots open for the various workshops for the conference. And yeah, feel free to register and join and attend. Thank you very much, Dr. Keisher, for this wonderful presentation. I'd like to thank everyone for taking their time to be able to join in the presentation. So have a good evening and have a good night. Thank you, Dr. and all the best.
Thank you for the invitation.
You're welcome. So I think at this point, people can leave at their pleasure. CPD points will be shared via email in due course. Thank you very much and have a good night.
Thank you. Good night, everybody.